HIPcast is brought to you by Enterprise Social Record. Today's episode of HIPcast is brought to you by MRO. MRO, the leading clinical data exchange company in healthcare. MRO is accelerating the exchange of clinical data throughout the healthcare ecosystem on behalf of providers, payers, and users of clinical data. MRO supports health systems, hospitals, and clinics by simplifying the exchange of information with requesters through release of information and revenue integrity solutions. MRO's technology-driven and service-backed framework has enhanced efficiencies, reduced risk, and increased compliance for over 23 years. For more information on how MRO is empowering providers with interoperable solutions to improve clinical data exchange, visit www.mrocorp.com.
Well, we have a special guest today, somebody that's possibly not known to the larger HIM community. So if you are a health information professional who doesn't follow what's happening with interoperability and integrations in the healthcare world, whether it's from an IT perspective or a business perspective or a policy perspective, you're in for a special treat. So stay for the whole thing. Brendan Keeler is probably my most listened to voice in terms of getting my updates and op-eds, kind of all these opinions on, hey, this is what I see, this is what's going on between these vendors, and even some of the lawsuits that have been going on between EHR vendors and ancillary or other tertiary type information systems. Super fun to listen to Brendan. It's always informative. So I'm going to read a quick bio for you all so that you'll kind of know what we're dealing with. But today we're going to talk about the CMS request for information related to healthcare data exchange. And then we're going to talk about what it was like to get that opportunity to go to that like really quickly put together event of the RFI discussion in person in DC. And then we'll talk about what's happening just on the larger, grander scale between CMS or with CMS and the ASTP. Formerly known as the ONC. We'll call it Prince if you want to. All right, so I'm going to read. Brendan Keeler is a Portland-based interoperability practice lead for HTD Health, a leading strategic consultancy and development agency. He provides a subject matter expertise and executive partnership for all projects related to integration, interoperability, and connectivity, working with digital health, tech-enabled care, payers, providers, pharmaceutical clients, and more. He previously held product positions at Epic, Redox, Zeus Health, and FlexPaw. He also advises digital health startups, and he authors the Health API Guide, which I say you should all go follow. And he provides analysis on industry trends and interoperability and health tech regulation. Reach out to Brandon. We'll put his link to his social media in the show notes, so you'll be able to find him and follow him on LinkedIn and Twitter, and then you can just follow him wherever. So, Brendan, I appreciate your willingness to come and talk to people that you may not have spoken with before.
Well, I'm glad to be here and glad to be talking with you.
Awesome. So it sounds like an RFI session is just a heck of a boondoggle. What a good time that has to be. I mean, in Tennessee, we'd call it hootenanny, an RFI session, get into a big old hootenanny and have a good time. So I'm just curious, what was the CMS RFI session? Let's put some more acronyms in this conversation. And then why did it happen?
It's not a good health podcast without a bunch of acronyms. And so, yeah. But just to give the larger context, we are in a new administration, right? We are 6 months into Trump 2. And so the agencies they go through the norming, forming, sometimes performing, arc in each new administration as they reset who's in charge, as they staff up and transition things. And so we've had 6 months of that happening where it's like, what's going to happen in health tech? What's going to happen with the ASTP, formerly ONC, Prince? And so we've had that with the CMS, right? With, as Dr. Oz was, chosen and staffed, as Chris Klomp from Collective Medical moved over to, Medicare. And so this RFI, this request for information, is a policy tactic used by agencies to request information. They are largely divorced from realities of operations unless they have history in industry or they do surveys and things like that. And so across all agencies, you see RFIs used to figure out the state of things, the state of standards, the state of workflows, the state of demand for change, and where their energies need to be focused. And so that is how it's used. In this case, it's used even more so as a sort of an announcement that the CMS is back, is large, is in charge, that they're coming to really focus on health technology, and they want to pull, to listen, and then to rally the people involved around where they're going. So it was both listening and also sort of them saying that in the hierarchy of all these different agencies that are involved in healthcare within the HHS, the FDA, the NIH, the CMS, ASTP, OIG, we can keep going on the acronyms, that they are going to be doing a lot of the pulling and pushing, and kind of as they should, right? Like CMS is the nation's largest payer. And in by virtue of administering all these programs, Medicare, Medicaid, paying through to Medicaid, paying through to ACA, they have leverage to get things done across the industry for payers and providers. And to utilize that more for health technology is something that started under Trump 1, into Biden, and now into Trump 2 via the CMS patient access rule in the Trump era, the CMS prior authorization rule that is coming, that was first proposed in Trump 1, then revamped in Biden and finalized. So we've seen health technology, the CMS, start to pull at these things in a way that previously was just the ASTP and the provider side. Now CMS is sort of saying out there, saying, hey, we're going to be doing a lot more, and we're going to be leading the charge for a smaller, nimbler, perhaps ASTP, as their budget and staff has been cut significantly. But that health technology is first and foremost something that we're thinking about. And so that's the context for this RFI they put out that was 30 days, which is very quick for an RFI or for a comment period, that everyone had to get their comments in, and over 1,300 comments were submitted. I'm only 10% of my way through reading all of them. And there's a lot of garbage, is what I would call it, of people promoting their own product and not really suggesting policy things. But the listening session was midway through that comment period, early June, where they said, they invite only, they reached out to a number of organizations and people and said, hey, we understand that you have a vital role in this health technology ecosystem. And not only are we doing the RFI in this written format, in the comment format that is common, but we're going to have a listening session where it is not you listening to us necessarily, not the audience listening to the CMS, but the CMS listening to the industry, listening to the stakeholders. And so they had patients there, and they had, sorry, I'm rambling.
No, you're doing amazing, but you brought up that was a great transition from, what's it for to the live event. And it strikes me as you talk about, you were listing all the agencies that were involved. And I wanted to say, what about the OMB? But I didn't. What I really want to think about is, I don't remember a time, and Seth and I have been doing this for a long time, me longer than him because he's a baby and I'm not a baby. He's a young guy and I'm not. But I've never encountered so many agencies under HHS coming together in one place. Is this a new? Well, first of all, have you seen that to this scale where it's so complete with almost, if not all, agencies that would be involved in this being present? And then yes or no to that. But then is this breaking down the silos between those agencies to help stop some of the conflict in our policy? What are your thoughts on that?
That's the promise of it. I mean, have these agencies been convened before? Sure. Under Biden, under Mickey Tripathi, they sort of got together, the heads of the agencies, and said, hey, they're in that one room. But I think you're right that it felt a little bit different in that the CMS as the convener has unique weight, right? A unique power to them that they could convene and keep that going. And so, the session did kick off with Secretary Kennedy coming in a little bit late, and Dr. Oz did a little riffing on the stage and things, ad hoc, which was pretty funny to see. And he's obviously, as a TV presence, pretty good at that. But then, each of the heads of the different agencies going through in the NIH, FDA, with Marty Makary and others, each saying how they're behind this and that health technology is important, that they are aligned. And so, yeah, that's the promise. Like anything in government, we'll have to see how it nets out. But it does feel like in this, in an administration that does currently have, down the partisan aisle, control of Congress, control of the presidency. There's certainly a lot of alignment in that regard, at least for the next until the midterms. And so that I do think that is part of the reason for the urgency that was sort of like backing both the RFI, backing the session.
Yeah. So then let's talk about a little bit about what was it like? What were some of the policy highlights of the RFI in-person session, which is, I don't remember ever having that to the same kind of scale. I know we've had, hey, come and let's talk about this in most every administration. This was very different in that it had all those agency heads, but it also said to many of the leaders in the health tech space, come and talk to us about this. And they invite, it's like, come and let's talk through this from a policy and an operational perspective. So what were some of the highlights of that in-person session besides this was insane?
Yeah, I mean, it was like, it was insane, right? There's just like a Illuminati gathering of sorts, right? But what it was structurally was 3 different panels. I got to participate on one of them, sort of the provider data exchange well, the second one was sort of provider data exchange. So we had the patient panel to kick things off with some really powerful stories and narratives around, the need for further patient empowerment and patient access. We had the sort of payer-provider data exchange with representative from Aetna, representative from Revelier, a payer-provider data exchange platform, and some others. And then we had health information exchange writ large as the third panel. So we had those panels to talk about the state of things. That was phase 1. Phase 2 was the CMS getting up there and announcing 5 of their initiatives. And so those initiatives that they focused on were things that they've already said, hey, we're going to work on this. And some of them were very tactical, that they said, hey, we're going to data at the point of care, which is a CMS program that's sort of been around for a while that allows providers to access claims data at the point of care to have a better longitudinal picture of the patient's history, because claims data are a great central aggregator of diagnoses and procedures. That program has existed for a while, but been in pilot for that time period and has been on pause for almost 3 years. And so it's just been sitting there, unable to be used by providers. So QuickWin, they said, hey, we're gonna go make this available again so that providers can benefit. And then there were more, hey, these are directionally where we're gonna go, but they were sort of hinting, we need feedback, like focusing people on certain things within the RFI, within their comments. So a national provider directory to list out the organizations, the providers, and the endpoints, the technical endpoints associated with each, is something that exists in haphazard form today. They want direction on how far should we go here? Should it just be endpoints? Should it be, what should be the requirements for connectivity? Should we use digital identity for providers in some fashion? Was all sort of implicit about like them gathering and pushing people in that way. And then so all the initiatives they announced were within the range of, hey, tell us, we're saying we're going to do this, but we need your guidance, to more tactical. And so the other ones were CMS Blue Button is a program for patients' access to their Medicare data. They're going to look to expand that, to improve that. And there's some cool things they're doing at the next HL7 Connectathon to that extent. and then some digital identity, some things around digital identity and accessing, government resources via digital identity was another focus. And then trusted exchange, which could mean TEFCA, the Trusted Exchange Framework and Common Agreement, or it could not. They weren't really prescriptive. A lot of people who are pro TEFCA said, wait, they just said they're going to participate in TEFCA. They kind of hedged around it. And so those were the five pieces they announced.
Yeah,
that's good politics.
Yeah. Well, and I think there are, some people think that TEFCA is great. Some people think it isn't. Some people think it could be if we actually were to leverage it, right? And I think that's true of a lot of our policies. If we're not leveraging that and being able to operationalize what's coming out of health policy, then it's really not a win. Blue Button has been around for quite a long time, right? Many years.
Totally. And so it's Medicare beneficiaries can access their claims data, some light coverage information via they just log into Medicare, .gov. The idea would be to expand it to, is there prior authorization information? Is there clinical information? What else does the Medicare have that they can put into it? Should it be via sort of a digital identity mechanism rather than username and password? So they're going to improve it and expand it is the thrust of it.
Do you think the digital is some kind of blockchain key type setup? Do you think it's bio? What do you think it is?
Biometric is by and large what's being used and accepted. So you can see not a lot. You can see some early adopter patient or provider portals starting to implement digital identity. So usually it's ID.me or Clear or another, biometric identity vendor that when you want to go and create an account, instead of having the username and password or like the account registration form that you may have forgotten or have to call about, you can just go say, prove that you're Brendan Keeler and then get your account provisioned. So I actually went and did this I'm in Portland, but there's a hospital in Florida that has it set up with Clear. And so I was able to register and make an account really easily. And so that sort of digital identity is what's being proposed and used in TEFCA. I actually got the chance to do TEFCA individual access services the other day. So highly recommend people start to get out there and use this, because the promise of TEFCA is to expand beyond treatment purpose of use for traditional HIEs and give patients access to their data in a way that's not remembering every portal username and password. And it worked end to end. So that's cool. And so as we scale that and get more organizations either live on TEFCA or the successor to TEFCA, I'm kind of agnostic to the how. People tend to get their pitchforks up and talk about TEFCA or state HIEs. The how doesn't matter to me. Ubiquity matters. Making it work nationally matters.
I agree with that 100%.
The National Patient or National Provider Directory caught my attention because AHIMA or AHIMA that we're part of has been talking about national patient identifiers for many, many years. And it just blows my mind that we are, 2025, and we still don't have a national provider directory. We still don't have a national patient ID that can help a patient go across the country, because we're a very mobile group of people now. I travel all over. So I'm curious of the conversations around the national provider directory, if anything came in play around patient ID.
Yeah, sure. So on the provider directory, everyone's excited about it because those foundational building blocks, clean list of providers who are active and the organizations they're associated with, think about the leverage that provides everybody to just figure out where, if you can go down the street to a provider, as well as the digital communication methods. Certainly tacked onto that is digital identity. That was another theme. And digital identity ties closely to a national provider identifier or patient identifier. And, we historically have not been allowed to do that because of the legislative barriers, and is one part of the potential solution. We in the U.S., our greatest strengths, anyone's greatest strengths is their greatest weakness. And so our decentralization, our focus on individualism means that big centralized solutions, the big database type health information exchange, the national patient identifier, are treated skeptically. Whereas in other countries, they're just sort of like, hey, just toss in the database, or hey, here's your, in the Netherlands, the BSN, right? Like your burger social number. is your national patient identifier. And so we treat that skeptically, which prevents government abuses, and there's benefits to decentralization, individualism, but certainly in the grand scheme of things, a national patient identifier is not a big database of everybody necessarily, and so or of all their clinical data. Like those are divergent outcomes and technical solutions. So I'm pretty pro a patient identifier, and I think it is overcoming the regulatory and legislative barriers to get us there. I don't think that's what the CMS is jumping to do. I think they're mostly hoping to orient around things that they currently can affect in the next 2 years without congressional action.
Yeah, I just wonder if a patient identifier is going to happen in my lifetime or my career. We'll say career, maybe lifetime, but it's like, even with, like you mentioned, the ID Me and the different digital identities that you can utilize. My mother, I helped her sign up for one to be able to sign into her Medicare stuff. And she was reluctant. Like, I don't want to give them my information. I'm like, they've already got your information. Like,
let me introduce you to the credit bureaus, right? Like,
So it's like we've got to get to that point in healthcare, right?
Yeah, I mean, digital identity is related but orthogonal to the national patient identifier, and is like that is what I used for TEFCA individual access services, right? Like I identity proofed using Clear, and it was really quick and easy. Just take the selfie and stuff because I already had registered for travel and things historically, and then once you've strongly identity proofed, you're able to pull and retrieve your information. And so that is a much closer reality. And the CMS could certainly accelerate those things by saying, for CMS services, we support these digital identity services, or providers and payers in the next 5 years need to start using or offering digital identity for patients as an option. Not the only option, right? I think there's a lot of people are really worried about the edge cases, less tech-enabled populations like elderly or less fortunate that don't have a cell phone, and so or something that they may struggle with services that are gated in that way. But offering it as an option certainly seems like a good middle ground that I think they'll gravitate towards, and we're seeing a lot of the comments that are policy forward for the CMS RFI propose things along those lines.
Yeah, I think it's interesting that a national patient identifier, from my own perspective, I'm like, I don't want everyone to be able to see my information, but I want my physicians that are caring for me to always be able to see my information. I mean, you talked about those different populations. I do jail ministry here in my local county, jail. And there are a lot of conversations historically when we talked about biometrics with some folks that had previously maybe been convicted of felons were very uncomfortable sharing biometric information. And I think that just is some guardrails we should put in place so that if you're part of if you're using biometrics for your patient identifier, that has to be walled off from your criminal history, I suppose. But then at the same time, you need to tie that to a PDMP where you can see their prescription medication utilization. I see great opportunity to connect those pharmacy data services to this.
You mean HIPAA from 1996 doesn't protect against all those things, Shannon? Come on now. That's a modern piece of legislation.
That was all paper. What's wrong with you? Brendan, this is such a fascinating conversation.
Yeah, I mean, it's certainly, these are the big questions, right? As we become more interconnected, right? As we now have data exchange that's going between 80% of providers pretty seamlessly, what's the right to privacy? Do we need patient control and consent is becoming the next big question. And that's for reasons like you mentioned, both reasons, bipartisan reasons, in the sense that both the left and right have reasons that they're saying, wait a minute, unbridled access has problems, right? Like the left in post-Dobbs is worried about law enforcement pulling from other states to prosecute abortion. Things like jailed populations certainly are important as people try to rehabilitate their lives after making mistakes. And so the next big era for us as we move past pure play access is we see abuses, right? Just like anything. When credit card networks were first made, there was fraud and abuse. And so fraud, abuse, overreaches are all things that we'll see and have to deal with. And I think the solutions we're gravitating towards and were brought up a lot in those sessions. And then the last piece of the listening session day was breakout sessions around patients, around provider directory, around provider exchange. Things like consent came up a lot. Things like patient awareness of or audit of where their data has been transferred or who's had access to it are the next thing to come as we hit the saturation point and start to see people misuse information.
Absolutely. Absolutely.
So Shannan, the last question that I see on the document here is more acronyms. Although we've mentioned them, but I have to read it because I don't have all the acronyms in my brain. I do appreciate the explanation on Blue Button because I'm sitting here going, I remember the blue light special at Kmart but that's about the extent of my experience with the blue whatever. But I'm curious, Brennan, what's to come in terms of CMS and ASTP and that movement?
Yeah.
Yeah.
One follow-up question on that is, are we now safe to call it the ASTP and not the ASTP ONC or the ASTP really known as ONC? Can we just say ASTP?
All three are acceptable. I bias towards something short and pithy, as you saw in my bio or whatever. Yeah, I call it ASTP. I think they're leaner, they're more nimbler, they're following the CMS lead, but they just, they've restarted the TEFCA monthly calls, and so you see them start to take actions there. I think there's a lot. I'm still parsing all of the comment letters. But there's a strong call for enforcement of information blocking. We have over nearly 2,000 complaints that have been submitted for this information blocking rule against providers, against health IT vendors, against health information exchanges. There hasn't been even one enforcement action. And so there's a large call from the industry to say, hey, this rule is outstanding. And people are so frustrated with the lack of action that was statutorily granted to OIG that they're taking court cases. They're doing these court cases like real-time medical systems against point-click care, like CureIS against Epic, like Intus Care against RTZ, are all information blocking issues that should be resolved by the complaint process that they got tired of waiting because their businesses and their providers and patients that they serve couldn't stand to wait to see what would happen year over year of inaction. And so they took it to the courts, and the court said, okay, you can actually use this workaround to not, even though there's no right of private action in the law, well, you can use state law to prosecute these and litigate these rather. And so that's not necessarily the right way to do things, but we're seeing some movement on what does information blocking need, and seeing the outcomes that Congress intended play out in the industry, which is good to see the realities of the law and stop information blocking if it occurs. But the reality is that the ASTP and the OIG need to figure out how they're going to investigate and enforce these things. Is a big call to action that we're seeing. I think we're going to see the CMS move very, very quickly on those priorities that they mentioned. Right? They understand as much as anyone that midterms are generally never good for a new administration, and that their mandate, the wind behind their sails may dry up in 2 years, and so certainly they're going to try and get things done. And I think that was exemplified by the listening session. Like, it was not, let's wait to get everything super polished, let's wait to put out the RFI. It was, let's go. And so it was a little rough around the edges at times, but that was, in my mind, good. It's not the traditional government like pomp and circumstance over effectiveness and get shit done factor.
Yeah, it's interesting. I've never seen an administration be as nimble as this one is currently attempting to be. Certainly, Congress is behaving the way Congress always does. It's a barrier, and I don't mean to say that's bad. Like, that's not what I'm saying at all. Congress is intended to take care of us, protect, and make sure that we're doing the things we're supposed to do. No matter where you sit, you want Congress to do their job. But sometimes Congress does get in the way of what we need in order to make policy actually work for the American people, right? Because you don't know if you're you kind of were talking about, Brendan, you mentioned way early in this discussion about, they're largely removed from what happens. They're not the boots on the ground. They are mostly disconnected from healthcare, right? That may have been a person in, life insurance or home insurance or in construction or whatever. That congressperson may be not have any historical experience with healthcare unless they were just a patient. So not understanding this is a great way to bring in the leads, people, your voice on that panel, right? Like having the discussion with people who are actually solving the problems in real time, even in our current policy constraints and freedoms that we have in healthcare policy, we're solving those problems, right? You're solving those problems now, but how do you see making it more effective and making it more deliverable and making it more accessible for continuity of care, right? Because the point is continuity of care. The data is important in terms of population health and things like that. But the most important thing is continuity of care, right?
100%. And one other theme along that lines is continuity of care with the patient at the center, right? Enabling them is something that this administration made very clear as a priority for them via this RFI. And so, yeah, improving continuity of care is important. And I think the exciting part is that the last administration, the ASTP, did everything they could to, Mickey Tripathi and the ASTP expanded their authority, pulled every lever, and tried to pull the boulder up the hill themselves, dragging the CMS, FDA, as much, all these different agencies. CMS, if they are doing the same sort of methodology and looking at all available levers, all available things they can do, the extent of their authority, they're going to find it's quite broad, and they can get a lot of things done. And so that's the excitement to take away from this, is that CMS can influence things in ways the ASP could really has very few statutorily granted levers, just the certification program, TEFCA, and those are some of these voluntary measures, whereas the CMS controls, programs that oversee 50% or more of Americans.
Yeah, and I love that. I think that your point about the ONC was Mickey was trying to do so much at pulling everything up the hill. It's interesting because you're right. ONC was ASTP is so small in scope compared to CMS or any of the other agencies within HHS. And then if you are looking at it at that higher scale, now you've got a push and a pull happening at the same time, right? Now you've got a more effective forward movement because you've got both sides of that, right? You've got the yin and the yang. But I appreciate you're talking about, was it you that wrote the CMS or the ONC? Mickey was pulling it up the hill. I saw that in an article. Was that your article I read?
I don't know but
I read it. I thought it was you. I thought it was probably you. Well, this is a fascinating conversation. It's important I think what I would love for our listeners to take away from this conversation today are 2 or 3 top things. The first one being that this RFI that went, 1,300 comments is really not a lot of comments but it was only 30 days, right? It wasn't a 60-day or a 90-day. I think it's a 90-day period usually, right? So
yeah, that's right.
And if you weed through what you called the garbage earlier and get to the ones that are really policy rich, if you can filter down on that, you can read all those. But I think that the things I'd like for listeners to take away from this is that while this seems like it's very specific to just healthcare data exchange and interoperability, it is that at the top, but that is impacting the entirety of the healthcare ecosystem. It's not just healthcare interoperability. So whatever your role is in healthcare will be affected by this. So everybody should be thinking about this from the macro impact and not just from this little RFI, right? There's probably going to be a myriad of policy that comes out of this. So that's one thing. The second thing is the way this discussion's happened, and the reason Brendan is here is we're health information professionals, which is mostly who our listeners are. We are very context focused folks. Like the data to us means a person's story. And the data to an IT person means the exchange and the road it travels. How does it travel from here to here? What's happening at rest of this data and what's happening in motion? And we have to have conversations together so that everybody understands that full map, right? Like Brandon needs to know, why is it important to get every detail of that condition to get the level of specificity we need to treat that person in the future, right? And then we need to know what Brendan needs to know, exchange, and what the limitations are and what the opportunities are. So that's my couple of takeaways. Seth, what are you thinking about this? What are takeaways like for our health information professionals to think?
I think you've nailed it. I'll just be Debbie Downer and say that it's a game of inches, and it's the government, and it's they're going to move fast in a short order to accomplish very little, and then it'll slow down, and we'll be just seeing where the noodle gets pushed down the bowl over the course of the next few years, and then if the administration, I guess there will be a new administration then we'll see what the priorities are. We'll see where they land. The noodle will get pushed a little bit further down the bowl, but hopefully by the time I retire, we'll have all this settled out and figured out.
All right, Brendan, would you call that a pessimist or a realist view of Seth?
It's a realist, but let's be optimistic about, I bias towards optimism. And so in this case, maybe they take a big cut and they get some big things done in this period. And yeah, will it be contested in court? Sure. People love to push back. And can we rely on Congress? No, certainly not. But the agencies, these agencies, there's some really great people working there in this administration that are hyper focused on some big problems. So I think that's I'm motivated because actually, Shannan, the 1,300, there were only 250 comments on HTI2, which was the 60-day comment period. So the ASTP's somewhat equivalent, sort of like related rule last summer.
Yeah.
250. So the outpouring of interest, and it doesn't compare to other agencies or perhaps other CMS rules, but for health technology, that's quite a lot in 30 days.
Yeah, good point. Thank you for looking that up. It is important. I wonder if a lot of that is because we're now mature in this, post HTI1 at least, right? And some of HTI2, but we're now a little more mature and we know we've learned a little, right?
Yeah, and I think the breadth of stakeholders that they called for, they said patients, payers, VBC, health tech, they really actively pushed out and said, we're open to comments from all, perhaps where HTI2 or HTI1 felt or read technical or read for a different stakeholder type. Could be it, but yeah, let's end with some enthusiasm and optimism because I think we need it in these times. And so if in this particular part of the administration we can get some really big things done, then let's go do it, is my take on it.
Yeah, I think I've been doing this since 1997 and I've never been more excited. Like the opportunities are insane and amazing and significant and I've never been more excited. Yes, I get tired because there are a million ways you can go in healthcare now and never be bored, but I'm excited. I think we have a lot of opportunity to push forward in exchange. And I also think, regardless of what people's personal perception is of RFK, I think that health care instead of sick care is his focus. And I'm all for some health care. I am all for some health care instead of sick care. Sick care should be reserved for people with naturally occurring chronic conditions and aging and people with short-term things like pregnancy or post-operative. Healthcare should be for everybody else. And I'd love to see us move toward healthcare instead of sick care.
And I think both sides of the aisle can agree on that from the way the Americans eat and some of those things, that there's a lot of opportunity to revisit that in a bipartisan way, that in terms of, and so like I heard that in person in regards to some of the changes to diet and food that we could use with health apps, use for Medicare beneficiaries, is some of the tie-ins that I heard in person.
Yeah, that's awesome. Well, thank you so much, Brendan. I love that you were willing to come on and talk about this. I also love your optimistic. It's finally somebody with me to trump Seth in his I'm like, hey, let's go. And he's like, that's dumb.
There's a realism about the government that we probably should have, but let's be optimistic as we head into summer.
I love it. Well, thank you so much. That was awesome. That was such a good discussion around the RFI. So thanks.
Thanks for having me.
Yep. See you next time, my friend Shannon.
All right. See you next time, buddy.